Welcome to Health System CIO's interview with Dr. Jeffrey Cleveland, Ambulatory CMIO with Advocate Health. I'm Anthony Guerra, founder and editor-in-chief. Jeff, thanks for joining me.
Well, thank you, Anthony. Look forward to our conversation.
All right, very good. So let's start off. Tell me about your organization and your role.
Well, so Advocate Health is the third largest not-for-profit health system in the country. We are a combination of Atrium Health in the Southeast region and Advocate Aurora Health in the Midwest region. We're 160,000 teammates. We take care of 6 million unique patients a year. We have, 20,000 physicians and APPs that are on our team. My role is the ambulatory CMIO for our Southeast region. So I work with my physician colleagues and with my IT colleagues to make sure that we're using technology to serve our patients in the best possible way.
All right, perfect. So we're here to talk about this report that you've done, which I am guessing this is generating a tremendous amount of interest. And the reason is because uh, there's a lot of burnout, right? Clinicians are burning out. They're kind of exhausted, overwhelmed. There's some IT associated reasons for that everyone's trying to get to and fix. One of the tools we're so hopeful for, are very hopeful for, that are going to help with that are things like artificial intelligence with the ambient listening and all these kind of things. Your report that came out, and I want to let you explain it. The name of the study is "Does AI-powered clinical documentation enhance clinician efficiency?" A longitudinal study. And sort of the conclusions, and I'm going to give you plenty of time to describe the conclusions as you see them, but it certainly wasn't, hey, this is amazing, this is unbelievable, 100% win. It was far from that. And that sort of, in my perception, um, probably made made a lot of people out there a little sad because they had hoped for more. And maybe there's more to come, and you can get into that. But tell me about the genesis of the report, um, why you decided to look at it, a little bit about the way you decided to look at things, and we'll go from there.
Great, thank you. And I'll just say that the data we published, I'm really proud of our research and analytics team. I'll absolutely stand behind the study. And the questions that we asked and answered maybe don't answer the whole story. And we address this in the article, so we can talk further about it. But so I have served on the Nuance, which is a subsidiary of Microsoft. I'm on their executive client council, which is basically just a group of physicians who represent large customers of Nuance, and we hear about their roadmap items and we give them input based on our own experiences and the needs of our company about their development products. So in the February 2023 meeting of the Executive Client Council, I heard about this new version of what Nuance calls DAX Copilot. We were already, like many health systems in the country, using a version of this that had a human reviewer in the mix. And so we were participating at that level. But in that meeting, I heard about the new fully automated AI-powered tool, and I was excited about it. And so I raised my hand and said, yes, we want to do that. So we set up fairly quickly in the spring of 2023 a research protocol in conjunction with Microsoft. We enrolled 125 physicians and APPs from our Southeast region, all of them from primary care, so family medicine, internal medicine, and general pediatrics. And then we started using DAX Copilot, an earlier version that we're using today. It was a DMO-based tool that would capture the conversation and give us a draft note, but you still had to copy and paste it into Epic. So some of the efficiency gains that we're experiencing now with the fully embedded version weren't available to us in 2023. I mean, we were the first health system in the world to use this tool starting in June of 23. And we added waves of users. We didn't know how much training and support it would take. So we took cohorts live every few weeks, and we had at the elbow support for them. And then we studied their time in the electronic health record, their time work outside of work, and compared that both to their pre-DAX baseline, seasonally adjusted, and also to a contemporaneous control cohort. So we were really focused on a couple of metrics. We wanted to know, does it really save you time? And does it generate revenue, right? So, I mean, if doctors are saving lots of time every day, it's reasonable to expect that they might start seeing more patients, and that would generate more revenue for them and for the health system. And that was one of the things we wanted to understand, because we do have to pay for the licenses now, and we needed to understand whether this tool had an intrinsic ROI, or ROI that we could measure. So as you say, we ran that for about 6 months, June to December last year. And our findings showed that if you take it a health system perspective and you look at the total group that we invited to participate, the average user saved a little time. The median user, I think we showed 17 minutes per day saved by the experimental group, and our control group saved 11 minutes per day. So the delta between what our intervention was saving was, negligible, and that's what we published in our study. And we didn't see doctors rushing to add appointments to their schedule. So from that standpoint,
Yeah.
it didn't have it didn't pay for itself. I'll say that much.
Okay, so we've got the idea that this was implemented. Now we've got this concept of versions, right? Things get better and better and better. So you mentioned the version that you started off at, even by the time you were finished, or certainly by this time, uh, it can do different things, and there may be more efficiencies, and that'll keep happening. So would you say the results reflect an earlier version to what is available now? And therefore, might not be comparing apples to apples with somebody who wanted to start down the path with what's available now?
Yes, I would absolutely say that. We we are not going to go back and do a formal controlled study again. We've
Mm-hmm.
done that. We've contributed what we could to this literature, but we're in a much better place right now with the Epic integrated version. So we're an Epic shop in all of our care locations, and we're using in our entire enterprise, we're using Copilot for Epic, which is the DAX that directly pulls the draft note into Epic for the physician or APP to then review, edit, and finalize. So there's a lot of increased efficiency in the experience of using it. And when we switched to that earlier this year, we saw a dramatic increase in satisfaction and interest in using DAX Copilot. So I told you a minute ago that it doesn't pay for itself, and it didn't save the average doctor a ton of time. But we call this out in our study. A subset of our physicians saved a huge amount of time. So we had almost 20% were saving at least an hour a day. That's a lot. And for some of our physicians and APPs, it was life-changing. That's why we continue to pursue it. So even though the average doctor didn't save a ton of time in the version that we were using then, they liked it and they wanted to keep using it. And we probed that, so that we have a second study that we published back in September in June, and that was a qualitative study, and it was really focused on the experience of the physician and APP with the tool.
Mm-hmm.
And in that, our colleagues, as we interviewed them and we evaluated the structured surveys that we did, we learned that our physicians and APPs appreciated that DAX was listening to all the details, and it would remember it for them, that they could make eye contact with their patients and just listen and not try to be quickly scratching something down, or even worse, typing, behind a screen on a keyboard somewhere. So the patient physician interactions were more satisfying to the physicians and anecdotally to the patients as well. So we talked about a cognitive burden or cognitive friction that was lowered by the use of the tool. So even our doctors who didn't save any time still found value in the tool. So it was probably November, December last year as we were finalizing and preparing to publish this data or seek publication for it, that we went ahead and started buying more licenses and expanding. And then in 2024, we are now offering DAX Copilot to all of our physicians and APPs, no strings attached in both regions. So we've got about 3,000 active users today and are continuing to offer it freely to anybody that wants to use it.
So that's very interesting. I mean, despite the findings, and again, so there's a lot here. So there's the idea that there was a cohort of users that saved a tremendous amount of time. Can you describe any characteristics about that cohort?
We're still trying to figure it out. We talk about the phenotype. What is who is that physician or APP that really benefits the most from this? And we've got some ideas. I think someone who is less facile with the use of technology and perhaps hasn't tricked out Epic to do all of the things that it can do efficiently, that person benefits more uh, with a tool like DAX than someone who's got all of their smart phrases and note templates and order sets
Hmm.
built. Um, so that's one thought. Certain types of patient encounters, if you're talking to a patient with acute illness, it works great for that. I've got a strep throat, right? Or if you're talking to a patient with 6 different medical problems and you go through the whole thing, it very adroitly lays those out for you. If you're doing a templated visit, like a well child checkup, for example, where you're going to talk about diet, development, sleep, whatever, a lot of the pediatricians that we work with, they had templates built. Essentially, all they had to do was fill in the blank for those categories of discussion. Well, maybe that's more efficient than using a whole narrative paragraph to say the same thing. OBGYN, where you're doing, prenatal checks again. So maybe more encounter type than physician characteristic specific, but perhaps some of both. I'll tell you, our goal really from the beginning, the whole reason we pursued this and have continued to do it is that what you said at the beginning of the show, we are concerned about our physicians and APPs. We want to enhance their professional experience. And at Advocate Health, we label this physician burnout amelioration. We call it best place to care. That's our internal tag for the initiatives that we're doing to try to make our physicians and APPs enjoy their work. We want to return the joy of their practice. And this, for many people, this does that. And it's one of several tools that we're pursuing right now. But for us, that was the answer to our question. Does this make our physicians and APPs lives better? And there was enough evidence that it did that for a lot of people that we were willing to make the investment and to continue to offer it broadly um, as we've done.
So, and that's very interesting, right? That you're buying more licenses. Um, and you mentioned because of the evidence, because you feel strongly that this is having a positive effect on clinician burnout, cognitive load, and all these types of things. Is it more anecdotal? The is that why you're going forward with this? You're like, we did our study and it measures certain things, but I just know from I've talked to too many people who are saying this is too valuable, so we're going with it. Is that kind of what's going on?
Kind of. We did a qualitative assessment, and roughly half of the people said, "Wow, this is significantly positively impacting my life." We did structured interviews. 2/3 of those people said, "This is significantly positively impacting my professional experience." And I get an email about every day saying, "Wow, this saved my marriage," or "I get to see my kids in the morning," or "I'm not going to retire like I had planned to do." So the other thing is just um, when you take a tool, a technology tool that you want a physician to use, or you're offering it for their use, and it's optional, the question is, do they use it,
Mm-hmm.
right? And I've been offering doctors tools that I tell them will make them more efficient for decades. And I've never had a tool which had quite the uptake and persistence of use as DAX Copilot. So um, we measure things like, of those who actually start using it, how many of them stop using it? And our number is about 4%. 4% of the people who actually go through the trouble of figuring it out and starting to use it drop it. And about 80% of those drop it in the first month after they start using it. And they figure out this isn't a good fit for me. I don't want to mess with it. And that's fine. Obviously, it's not for everybody. But if you got 96% of the people who use the tool keep using it, to me, that shows that there's intrinsic value there for the physicians. And then they tell me. So, yeah.
Okay, you use the phrase "go through the trouble of figuring it out." How would you describe what that entails, and how do you make it as easy as possible for them to get through that learning curve?
It's actually pretty easy. You turn on the microphone, you start your conversation, you turn off the microphone, and then you sit back down at your computer. So it's not a hard learning curve, but really, I mean, I'm talking to a bunch of physicians and APPs, and they're very busy,
Yeah.
and they don't all read their email, right? Because they're very busy with other important things. And I understand that. So change management with this group of highly trained professionals is challenging. Just getting their attention is challenging. And that was some of our early experience was, if you would just listen to me and try this thing for 20 minutes on Monday morning, we think you'll like it. But that's a bit of a barrier to overcome. Now what's happening is their colleagues are all saying, you're not using this? What's wrong with you? This is saving my life. Here, you got to try this. Yeah. So the grassroots conversation is now doing the marketing for me, and that's made it a lot easier. But to answer your question about what did we do to try to make it easy, we have been taking groups of people live in monthly cohorts. So that allows us to follow up on the last group, and we reach out to make sure that they don't need support, especially if they're not using the tool. We can tell if they're using it or not, so we'll follow up with them and help them get activated with at the elbow support if they need that. And then when we're preparing to go live with our next group, we have a town hall where we invite them all to come. I walk through the tool, I give them a demo of how it works, and then our team sends them a package of information with a lot of um, education and FAQs, and well, here's what you do next. So we've streamlined that. The vendor's done a good job preparing a lot of that material, and we've packaged it for our teams. And then, so that always happens on a Thursday evening. And then on Monday of the following week, we turn it on for that group of people who registered and said they wanted it. And then we've got, I offer office hours, on Tuesday mornings, so they can drop in with questions. And we've got a variety of Teams channels and other things that we use to support our users, but it's pretty easy to use. And we end up answering the same questions all the time. You can't use it on an Android device, right? That's the main one. I'll have a lot of people, I'll say that to them 10 times, and then they'll call me on Monday and say, it's not working. Well, right, it won't work on your Samsung device yet. That's supposedly coming next year. We're eager for that.
All right, very good. So when you do get uptake, when people do try it, for the individuals that you see have stopped using it, and you go back to them, I assume, and say, Why don't you use it anymore?" What's the reason?
Well, I did that for a while. I don't do it anymore because it's on such a scale. I mean, I have 3,000 active users, and we're adding several hundred a month as we go. But yes, the themes were, it just didn't help me that much. I'm efficient enough, or the kinds of visits that I have, it doesn't fit in. If you're doing surgical procedures in your office all day long, injecting knees or shoulders or things like that, it probably isn't going to be of as much value to you as someone with a narrative intense encounter with their patient.
Hmm.
Because this is about dialogue, right?
Mm.
So it isn't reading things out of the chart and putting a note together. It's only taking the content from your dialogue with the patient. So if you don't have a dialogue based type of workflow, it maybe won't serve you as well.
Makes a lot of sense. Makes a lot of sense. So I assume for those individuals, probably you're seeing less of a not a non-adoption rate for people that have big narratives, long discussions with complicated patients, where it's really valuable because it's capturing that 15-minute really complicated conversation, and it's giving it to you in a nice, organized, clear way. I mean, who's going to turn that down?
Well, exactly. And the physician whose job is to do joint injection, I mean, I'm so grateful that she's doing that, but
Yeah,
she doesn't have much to write down, right?
right,
But
right.
the person who's interviewing you for your 16 chronic medical problems, there's a lot of note creation burden that
Sure.
this alleviates. So I actually just met earlier today with the team from Microsoft and a couple of our psychologists because we're development partners with Microsoft with DAX, and we've got several new things that we've been working with them to develop. One of them is this model for behavioral health, which has unique sort of conversation compared to other primary care stuff. And so that's exciting. I think that's a whole group of I've been having our psychiatrists and our psychologists use DAX, but they're using a primary care model. And so this new algorithm, which is oriented to the kind of conditions that they're managing and conversations that they have, I think will be more beneficial to them once that's fully baked.
So we think maybe, the value in here is perhaps just not in the specific things you measured in the study. We see a ton of value. The study said the numbers of minutes saved were minor, but we're still seeing there's tremendous value that just didn't happen to be measured with what you were measuring. Is that the case?
I think that's
Yeah.
fair. And if you're the doctor that's saving an hour a day, that's valuable to you. So for a subset of the population, I think that that can be huge. And if you take the 20,000 physicians at Advocate Health and come up with 20% of those, that's a lot of people who are saving an hour a day. And that's a big impact on my colleagues. So when we have it fully available to everybody and everybody's using it, we think that we're going to see it raise that experience for folks that have struggled.
Yeah, what's also interesting is I'm guessing that if you studied the note that was produced without this tool of the encounter versus the note that was produced with this tool, I'm guessing you'd have a much better note that was produced with the tool. And therefore, there's some patient safety upside there because you're getting a better note. Even maybe you didn't save any time for whatever reason, but look at those two outputs and tell me which one has a better representation or better capture of our discussion. Does that make sense?
We found that.
Yeah.
I won't say anything disparagingly about the old notes that my colleagues write, but I will say that the DAX notes are comprehensive because they capture everything you talked about with the patient
Yeah.
and nothing that you didn't talk about with the patient, right?
Right.
And so, I would be very interested in doing a study which looks at the patient's experience of reading their notes on our portal because we've been live with open notes, right, since 2015. So every note that a physician or APP writes in our system is available for the patient to read, with a few exceptions. I would really be interested in seeing what the patient's experience of that is. I think they will see that it's comprehensive, and I think they'll see that it reflects their voice better, perhaps than our legacy notes did, because this is based on a dialogue. And so it does capture that what's important to the patient today is going to be captured in your note.
And I got a fun one for you to think of, to think about. I bet you if you compared, let's say you have a very long encounter, a discussion with a patient, which I would imagine long might be 20 minutes. That would be really long, right? A dialogue with a patient, maybe. I bet you if you studied the last 5 minutes and see which captured the last 5 minutes better,
Hmm.
because people get tired. People
Mhm.
get tired. If somebody's taking notes or whatnot, or even listening,
Sure,
that
sure.
trails off at the end. But the AI doesn't trail off at the end.
Doesn't get tired. Yeah, I don't know. That is an interesting thought. One of the things that has been a new feature with this tool is that we can now apply our own style to it.
Mm,
So I prefer a more concise note, and I want
mm-hmm.
my impression and plan in bullet points because I don't have the patience to read through the whole paragraph. And so individuals can set their notes up to still capture all of the content, but present it in a more verbose or more concise way. You can dial
Yeah.
medical terminology up or down. You can make it more patient friendly or more medical terminology heavy. And that's cool.
That's really cool. I think this stuff is really cool. So, I think it's very cool that you guys are doubling down on your licenses and going forward. And I guess everybody's going to be. And maybe just the study just gives some, some people some things to think about. But certainly it seems like that everyone should keep moving forward with this. Let me ask you something about this concept of integration with the core EMR and that making it more attractive. One of the big themes, discussions I've been having with people is this concept of there's an upside on the technology side from staying within your core EMR vendor's offerings. It makes everything, it's cheaper, it's easier, it's integrated. You mentioned within the workflow. Some people think that that stifles innovation when you're more resistant to going to outside, let's call them niche vendors. Let's just call them vendors outside your core EMR for specific tools. And people love that. Users love that. Innovation people love that because your EMR vendor is doing a lot of things and they may not be hitting it out of the ballpark with the little niche things. So there seems to be this sort of tug of war between uh, that IT side of staying in suite or whatever you want to call it, and this sort of innovation. And there's a cost to pay when you go outside of suite. And you mentioned it, which is it can be outside the workflow. And you talked about the benefit of when you got it inside the Epic workflow and how that increased user satisfaction. Um, so I don't know. What are your thoughts there around? You probably not too much. On the IT stack and all that and making sure that's consistent. But I'm sure you deal with your CIO and have those discussions. What's your overall thought on this kind of dynamic?
Well, so to be clear, the tool that we're using integrates with Epic, but it is not an Epic tool. And so this is a third party vendor whose tool is interfaced with Epic. And we looked, Anthony, I looked at 6 different AI scribes very carefully, got demos from all of them, strongly considered a couple of them, weighed the pros and cons. And one of the factors that made a difference for me was we wanted a tool that could be integrated within Epic. And there are several who have APIs into Epic and allow their ambient content to be consumed into the Epic notes. And so that became our short list. And I think for me, it was more important that I have a really good tool that is in the workflow for my physicians and APPs than maybe some of the other priorities. Now, uh, we're excited about innovation. We want to be building our own tools as a large health system with that kind of research and analytics team. I think we're we're eager to explore that as well as shaping the tools. So I mentioned we've been a development partner with Nuanced Microsoft on this and are contributing to their um, adjustments to the tool as they continue to enhance it. But that decision isn't the one we make for everything, for sure. At some point, the function of the tool, how well it works, how well it does what it purports to do, is the most important thing. And if this tool didn't work well, it wouldn't help that it was interfaced with Epic, right? But because it does, then we prioritized the ease of all I have to do is open up my note template. The content is instantly in front of me. I saw 20 something patients on Wednesday. I used this tool for every patient that I saw. I clicked a single button to open my established template, which pulls all the content in, reviewed, edit, sign. I was done with all of my notes at 5:30 in the afternoon on the way out the door. So that's a valuable thing when you can give a doctor a tool that sits already where she's working all day, then that just one less thing for her to have to keep up with.
So I guess we have different levels here. We've got sort of an Epic tool that they've developed, right? There are Epic tools and Epic modules and things that Epic does, right? So then you
Sure.
have that. That's loaded native and right there. And then you have something like this, which are the tools that are developed by other vendors that are pre-integrated. So it's all
Right.
done. It's all now I don't know if that's as good in terms of workflow as a tool that Epic built. If there's some degree of difference there with how that feels. And then you have a tool that may be amazing and mind-blowing, but they haven't even talked to Epic yet. Right?
Sure.
So
Yeah.
so the does that make sense in terms of the three
Yeah.
three kind of
No,
ways
it
of looking at
does.
that? Go ahead,
Uh,
tell me your thoughts on that.
well, so the interfaced tools, if they're done well, uh, it's a fairly transparent experience, right? So one of the things we're working on with Microsoft now is being able to just turn on the microphone that's attached to the computer in the room
Hmm.
instead of having to do it on my device, right? So right now I have to cover a mobile device. I open up Haiku, which is Epic's mobile solution. I select the patient off the list. I hit the record button. I have to do all that on my mobile device. But some of my colleagues have said, I don't want to carry a device around. I just want to use one in the room. So that's on the roadmap. That would be a greater integration than what we're experiencing today.
Hmm. Hmm.
But the interface is pretty good. And so if I sit down at my computer, I open Epic, I don't have to think about Microsoft or Nuance or any of that. And I simply open my Epic note and there it is. There's not much to complain about. Now, we're an Epic first shop. That's part of the philosophy of our IT leadership is that if Epic has a pretty good tool that will do something, we're going to use that rather than use a really good tool that we have to somehow shove into our stack because of the workflow issues and the maintenance issues and the licensing costs, et cetera. But I've got half a dozen AI projects that I'm leading right now. Many of them are Epic. So we're doing Epic chart summaries where, it reads the last 30 notes and it gives me a one paragraph summary. We're doing an in-basket tool that reads a patient's question and writes an answer for my
Mm.
triage nurses for them to then consider and use. And we're really benefiting from those tools, but Epic doesn't have an ambient scribe tool,
Not yet.
not yet, and we'll consider it when they do.
Yeah.
But right now, what they've got is they've got the interface that allows a couple of vendors to plug in, and so that's the path we chose.
Very interesting. So if you had a physician come to you and say, was just at this conference and this thing's amazing and it's mind blowing. One of the first things you might look into is do they have anything to do with Epic? And if they don't, that's going to be a pretty tough sell.
Yeah, it would be a higher bar. We would look at it.
Hmm.
And that's one of the things that our CMIO group does is that we look at these different tools and then we consider what is our need, what's the
Hmm.
problem we're trying to solve, can Epic solve it as well as or close to, and if not, then we have lots of interfaced integrated systems, obviously within our technology suite on top
Well,
of or beside or integrated with Epic. Um, but we try to keep it as streamlined as possible just from a overhead maintenance standpoint.
yeah, so let's try and play with some fun numbers here because you talked about pretty good and getting close. I had heard in the past CIOs use the term 80% in terms of, hey, listen, users, if it does 80 per, if Epic or our in-suite tool does 80%, please live with that. Live with the 80%. I was had someone on a discussion the other day who was on the innovation, more on the innovation user side, operations side, clinical, who said, you know what? When they say that to us and we look at it, it's often closer to 30%. So it's not 80, it's 30, and they're telling us to make do with 30. So it's just a really interesting dynamic right now. Anything further you want to add?
I think that having chief medical information officers, I'm not promoting my role, but we have a team of a dozen physicians who are actually using the tools to take care of patients. So we know the difference between 30% and 80%. And so we can help advise our CIO about how is this really going to serve our patients and our physician and APP and nursing colleagues. And so I think that's one of the values of our role, is that we can bring a real gut check to some of those kind of hype numbers. I would agree with 80%. If it's 80% of the job and is integrated, that works for me. But there's a judgment to be made, as you've said.
I'm not going to keep you much longer, but I'm having a really good time here. Um, let's talk about soft, hard ROI, and with an eye towards giving your colleagues some points of discussion that they could bring to their CFOs and COOs and CEOs when they're saying, we need to do this, we need more licenses. I know this works. I know this is making people happy. What's your best advice to them on how they can get that spend approved?
Well, right now, I think this is a differentiator. I think AI scribes will be table stakes in a few years, just expected as part of the tech suite for almost everybody. But Advocate Health wants to be the best place to care. We want to be able to recruit and retain residents that are in our training programs. We want them to want to work here and to be able to attract the best talent. And so we want to make their professional experience as positive as we can. And that includes bringing things like the best technology to the table. And we will continue to pursue that because it's important for us that that's part of our culture. The other side of that coin is that it costs $1 million to replace a physician on average. So if I've got to go find a new cardiologist or a primary care doctor or OBGYN because they retired earlier, they left, or they burned out, or they cut their hours way back, wow, that's an expensive investment. It's hard to measure. It's soft ROI, to your comment. We have a hard time attributing the people that didn't retire because they had DAX. I mean, there are some that tell me that, but it's hard to measure that.
Mm-hmm.
And so I think it's a real phenomenon. It's just hard to quantify.
So I'm sure you save all these anecdotes and anonymize them and can use them in your presentations, right? I mean, that's one thing people could do. If you're at a health system and you get some licenses and you get this rolled out, you're getting those stories, because that personal story can be leveraged in a presentation in place of hard numbers and stats that may not be there yet. Make
I have
sense?
pages and pages and pages of quotes that I absolutely keep a record of. Um, and some of it's just to encourage myself that this is a valuable thing to be
Yeah.
invested in. So,
All right, Dr. Cleveland, Jeff, thank you so much for your time today. This was a really wonderful conversation. And yeah, it's pretty exciting stuff. I'm with you. I'm excited about it. So let's keep
hey,
having fun with AI. You
yeah,
have a great day. Thank
thanks
you
for the
very much.
invitation, Anthony. Great talking to you. Bye bye.
Take care. Bye.